This topic is valvular heart disease and murmurs, Part 1, Systolic murmurs. Let's start with some pathophysiology. The heart valves allow blood to travel through them and are also supposed to prevent blood from flowing backwards. The valves of the heart are the tricuspid, pulmonary, mitral, and aortic valves. Valvular heart disease is heart valve malfunction. This can include stenosis, regurgitation, and prolapse. Stenosis is the valve cannot fully open due to constriction or narrowing. Regurgitation is the valve cannot completely close. Mitral valve prolapse is when the valve does not close properly. These can be congenital, when the client is born with them, or acquired. A murmur is the sound of turbulent blood flow through the valves. It is an extra sound that is heard during the heartbeat. You can see in this image where each of the different murmurs can be heard best. Causes of valvular heart disease include narrowing of a heart valve, a defect of the atrial or ventricular walls. Changes in the structure of the heart can cause dysfunction of the valves. A pathological increase in blood flow from fever or hyperthyroidism, an infectious disease like rheumatic fever, which causes inflammation and scarring of the heart valves. Types of murmurs. Diastolic, which occur during diastole, during ventricular relaxation as the ventricles are filling with blood from the atria. An example is mitral stenosis. Systolic murmurs, what we will be talking about in this video. These occur during systole, during ventricular contraction, when the blood is being ejected from the ventricles to the pulmonary artery or the aorta. An example is mitral regurgitation. You can see in the image which valves are opening and closing during diastole and during systole. You can see the causes of a systolic murmur here in this list: mitral regurgitation, mitral valve prolapse, aortic stenosis, pulmonic stenosis, atrial septal defect, and ventricular septal defect. We will look at these individually in a moment. Let's start with mitral regurgitation. This is incomplete closure of the mitral valve during systole. You can see it here in the image. Normally, blood travels from the left atrium through the mitral valve to the left ventricle. Regurgitation results in backflow of blood into the left atrium because the leaflets are not closing completely. This can cause left atrial and ventricular dilation and hypertrophy because the left atrium and ventricle have to work harder to maintain enough cardiac output, and due to the increased volume of blood. Risk factors include mitral valve prolapse. The leaflets of the mitral valve are not functioning properly. Rheumatic heart disease, damaging the mitral valve. Infective endocarditis, causing inflammation of the heart valves and the inner lining of the heart. Dilated cardiomyopathy. Any change in the heart shape can potentially cause dysfunction inside of the heart. And Marfan syndrome, which is a connective tissue disease. Clinical features of mitral regurgitation: fatigue and chronic weakness from the decrease in cardiac output, palpitations, dyspnea on exertion, pulmonary edema, orthopnea, difficulty with breathing while lying down. Right-sided heart failure may develop, causing neck vein distension and pitting edema. And a high-pitched systolic murmur. You can hear an example in this audio clip. Mitral valve prolapse. The mitral valve leaflets become misshapen. They enlarge and protrude into the left atrium during systole. If a leaflet is severely stretched, the valve does not remain closed during systole. This may progress to mitral regurgitation. Clinical features of mitral valve prolapse. Some clients may be asymptomatic. Others may have atypical chest pain, which they will experience when they are resting. The clients may experience dizziness, syncope, and palpitations, and these may be associated with the chest pain or be without chest pain. The client may develop dysrhythmias like atrial tachycardia, ventricular tachycardia, and premature ventricular contractions. With auscultation, you will hear a systolic click. You can hear an example in this audio clip. Aortic stenosis is a thick and narrow aortic valve opening. You can see that in the image here. Blood is unable to flow normally from the left ventricle through to the aorta. Let's take a second and repeat that. Blood is not able to flow normally from the left ventricle through the aortic valve to the aorta and to the rest of the body. This is important to remember. Risk factors include a congenital bicuspid or unicuspid aortic valve. The aortic valve should have 3 leaflets. A bicuspid aortic valve has 2 leaflets, and unicuspid only has 1. Another risk factor is atherosclerosis or degenerative calcification in older adults, and rheumatic heart disease. Clinical features of aortic stenosis. Again, some clients may be asymptomatic. Others may have angina, dyspnea, and syncope with exertion because the heart cannot increase the cardiac output to fulfill the needs of the body with exertion. Fatigue, orthopnea, shortness of breath while lying down, and paroxysmal nocturnal dyspnea, a sudden onset of difficulty breathing while sleeping. Now, because the heart must work harder to push blood through the stenotic aortic valve, left ventricular hypertrophy may result. There is decreased cardiac output, and this can lead to heart failure, pulmonary hypertension, and decreased tissue perfusion. You will hear a loud, harsh systolic murmur. You can hear an example in this audio clip. Pulmonic stenosis. This is narrowing of the pulmonary valve, and this restricts blood flow from the right ventricle into the pulmonary artery leading into the lungs. Typically, this is congenital, so the client is born with it, and it is an isolated defect. Clinical features of pulmonic stenosis. Increased right ventricular hypertrophy because the right ventricle must push harder to force the blood through the stenotic pulmonary valve. The client may experience difficulty breathing, fatigue, angina, and syncope. When the stenosis becomes severe, it will cause atrial dilation. It may also cause pulmonary atresia, which is total fusion of the valve. No blood flows to the lungs. This becomes life-threatening. Pulmonary stenosis causes a decrease in cardiac output, and the client will have a harsh systolic murmur and ejection click. A thrill will be auscultated at the upper left sternal border. You can hear an example in the audio clip. Now let's talk about septal defects. Remember, the septum separates the right side from the left side. Atrial septal defect. This is a congenital heart defect in which there is an abnormal opening between the right and left atria. Because there is more pressure on the left side of the heart, there will be a left to right shunting of blood, resulting in more blood going to and through the lungs. An atrial septal defect will cause a second heart sound that is split. That means that the second heart sound is not one sound, but it is two sounds. It happens because the aortic and pulmonic valves are not closing simultaneously. Ventricular septal defect is an abnormal opening between the right and left ventricles, again causing a left to right shunt, resulting in additional blood being pumped to and through the lungs. You can hear an example of what a ventricular septal defect sounds like here in this audio clip. Management. Medications. You will notice that many of these medications are used for the treatment of heart failure. The client may be prescribed diuretics for excretion of excess fluid volume, beta blockers, slowing the heart rate and decreasing the blood pressure by relaxing blood vessels, ACE inhibitors, angiotensin converting enzyme inhibitors. These are used to lower blood pressure by relaxing veins and arteries. Digoxin to increase contractility and slow the heart rate. Calcium channel blockers used for vasodilation. They may be used for clients with mitral or aortic stenosis to decrease the backward flow of blood. Nitrates. These are given carefully to clients with aortic stenosis because it may result in syncope due to the reduced preload or volume in the left ventricle. Warfarin for chronic atrial fibrillation or mechanical valves to prevent the formation of any thrombus. Surgery. Valvuloplasty for valves that have stenosis. This is performed during a cardiac catheterization. It is done to widen a stenotic valve. A balloon is inflated in the valve to open it. This technique can also be used to deploy a new valve over the diseased valve. This is an option for clients who may not be healthy enough to undergo cardiac surgery. Mitral annuloplasty or reconstruction. This is placing a full ring or partial band around the annulus, or the base of where the valve connects to the heart. This is done to the mitral valve to fix its shape. The surgeon may also shorten or repair the leaflets of the valve during surgery. And valve replacement. Valves can be replaced with a mechanical or biologic tissue valve. Nursing interventions. Assess heart rate, blood pressure, and respiratory rate. Auscultate heart and lung sounds, listening for worsening of the client's condition. Assess for manifestations of heart failure, looking for fatigue, dyspnea, and cough. Monitor for arrhythmias, like atrial fibrillation. This is especially important for clients with disease affecting the mitral valve because the filling of the left ventricle is dependent upon the contraction of the atria. With atrial fibrillation, the contraction is not organized and potentially not as powerful. This will result in decreased cardiac output and heart failure. And any blood that remains in the left atrium may form a thrombus, potentially leading to stroke. Client teaching. Avoid strenuous activity and prioritize rest. The client should plan periods of rest if they are participating in any sort of activity. Use nitrates cautiously for clients with aortic stenosis. because they may cause syncope due to a reduction in preload. Prophylactic antibiotic therapy before invasive or dental procedures. This is important for clients with valve disease and after prosthetic material has been used to repair a defect in the heart or heart valves. To prevent infectious endocarditis, which can further damage the heart and the valves. Notify the provider of signs of infection or signs of heart failure. Clients will require lifelong anticoagulation for mechanical valves because the mechanical valve places the client at increased risk for thromboembolism. This will require blood tests to determine therapeutic levels for the client. And we will teach the client about bleeding precautions, using a soft bristle toothbrush, using an electric razor to shave instead of a straight razor, and safety with avoiding falls with clear, well-lit pathways and removing throw rugs in the home. Keep up the hard work. I'm proud of you.